All right, let's dive into something specific today. We've got a set of revision notes here, really zeroing in on non-falciparum malaria.
Yeah, it feels very much like, prep material for something like the MSRA exam here in the UK.
Exactly. So our job today is to take these quite detailed notes and, well, turn them into your high-yield, easy-to-remember study guide. We want to unpack the crucial stuff.
Explain why it matters and, help you lock it down for revision.
Think of this as turning static notes into, well, a dynamic conversation you can take with you. Malaria itself, it's ancient, globally significant. Plasmodium falciparum gets loads of attention, obviously, because it's the deadliest. But these other species, the non-falciparum types, they have really important distinctions.
Absolutely crucial, especially if you're dealing with travel, medicine, or maybe practicing in a non-endemic country like the UK where you don't see malaria every day. Understanding these nuances is key.
Okay, let's get into it then.
So, starting right at the top, the definition from the notes. What is non-falciparum malaria? Well, simply put, it's malaria caused by Plasmodium species other than Plasmodium falciparum.
Right, and the notes list the classic trio here: Plasmodium vivax, Plasmodium ovale, and Plasmodium malaria.
Plus, they correctly point to an increasingly recognized player, Plasmodium Knowlesi, particularly found in Southeast Asia.
And that one's important because...
Because unlike the others in this non-falciparum group, Knowlesi can actually cause severe disease. That's a really key distinction.
Okay, good point to file away immediately. Geographically, where are we finding these? The notes give a bit of a map.
Yeah, Vivax is pretty widespread, often seen in Central America, the Indian subcontinent. Ovale, that's mainly found in Africa. And Knowlesi, like I said, Southeast Asia specifically.
Got it. The notes also give that wider context, don't they? Ancient disease, huge impact on developing nations.
Particularly Africa. Over half the cases and deaths. It's a massive economic burden, too.
Which is why you have these big global initiatives like the Rollback Malaria Partnership aiming for eradication eventually.
Exactly. And for you listening in the UK, a really critical point the notes highlight. Malaria is a notifiable disease here.
Meaning, if you diagnose it, you have to report it, legally required.
Absolutely. Okay, so let's look at the etiology. How does this actually, happen? It's caused by Plasmodium parasites, and they're transmitted only by infected female Anopheles mosquitoes.
And it's the specific species of Plasmodium that determines the type of malaria. The notes use some older terms, but they're still helpful. P. vivax is called benign tertian malaria.
P. ovale is known for its relapsing course. We'll come back to that. And P. malariae is benign quartan malaria.
Right, those cycles. But don't forget Knowlesi again.
No, definitely not. The notes really single it out as an emerging species that can cause severe malaria, unlike that benign label on the others. That's, a potential exam question right there. Which non-falciparum species can be severe? Knowlesi.
Good shout. Okay, let's trace the parasite's journey, the life cycle, focusing on what the notes emphasize. Mosquito bites you, injects sporozoites.
Right, these little sporozoites, they're fast, they head straight through the bloodstream to the liver. And here's where it gets really interesting, especially for Vivax and Ovale.
Ah, the liver stage.
Exactly. In the liver, these parasites can either start maturing right away into the next stage, or, and this is the crucial bit, they can just hang back, become dormant forms called hypnozoites.
Hypnozoites. Okay, this is the critical detail for Vivax and Ovale, isn't it? That's why they relapse.
That's exactly it. They can cause relapses months, even years after the first infection seems totally cleared. These hypnozoites just wake up later.
Wow. Okay, so what happens after the liver stage, whether they matured straight away or woke up?
Well, the mature parasites burst out of the liver cells as merozoites. Loads of them flood into the bloodstream.
And that's where they invade the red blood cells.
Yes. Inside the red blood cells, they multiply like crazy, asexually. This cycle of invasion, multiplication, and bursting out of red cells is what causes the symptoms.
And then another mosquito comes along, bites the infected person, picks up the parasites, and the cycle continues.
Precisely. So who's most at risk? The notes are pretty clear. Basically, anyone traveling to or living in endemic areas without proper protection.
Yeah, simple things like using mosquito nets, good repellent, and critically, taking the right prophylactic medication if it's recommended for where you're going.
Definitely. The notes also highlight specific groups at higher risk. The poor, very young kids, pregnant women, the elderly, and crucially, people who don't have immunity, so travelers from non-endemic places like the UK.
And for those travelers, the notes list some specific risk factors too, like destination features.
Right, places with high humidity, those warm 20-30 degrees Celsius temperatures, high seasonal rainfall. Also, sticking to rural areas, staying in maybe cheaper, less protected accommodation.
Being outdoors between dusk and dawn, when the Anopheles mosquitoes are most active, and just spending longer periods in these areas.
Yeah, duration matters. And they even mention that slightly, well, weird but fascinating concept, airport malaria.
Oh yeah, I saw that. So cases popping up miles from any endemic zone.
Exactly. Because an infected mosquito literally hitched a ride on a plane. It's rare, definitely rare, but it just shows how interconnected things are with global travel. Even connects us to tiny insects.
Wild. Okay, so how does all this parasite activity translate into feeling sick? The pathophysiology bit in the notes is quite brief.
Yeah, it connects the dots. Parasites enter via the mosquito, hit the liver, burst into the blood, infect red cells. It's the destruction of these red cells, plus the parasite waste products released, that triggers the body's immune response. That leads to the classic symptoms, especially those cyclic fevers.
Which is a perfect lead-in to differential diagnosis.
Right.
Because if someone walks into, say, a GP practice in London with a fever and feeling rubbish,
Malaria probably isn't the first thing that springs to mind, right? The notes give a really important list of things that can mimic malaria.
let's run through them. Typhoid fever, hepatitis, dengue fever, good old influenza, HIV seroconversion illness.
Also meningitis or encephalitis, viral hemorrhagic fevers, things like Ebola, though much rarer, and leptospirosis.
That list is vital because it just screams one thing, doesn't it?
Travel history, absolutely. As the notes imply, asking where someone has been recently is probably the single most important question to even start thinking about malaria and narrowing down that broad list.
Crucial. Okay, let's switch focus to epidemiology, particularly for our UK listeners. The notes state it clearly. Malaria is not endemic in the UK, full stop.
Correct. So all the cases we see here are imported, people coming back from ships or immigrants from areas where malaria is common.
And the notes give some UK numbers, typically, between 1,300 and 1,800 cases reported each year?
Yeah, something like that. And sadly, that results in around 2 to 11 deaths annually.
They give the specific figures for 2019. 1,719 cases and 15 deaths that year.
And they point out that the vast majority of those cases, about 85.8%, were P. falciparum, which again just underlines why that species is the big worry for severe disease and death.
And most of those UK deaths in 2019 were from infections acquired in Africa.
Now, here's a statistic from the notes that really, really needs to stick with you. It's a critical takeaway for anyone advising travelers.
Go on.
87%, and for 87% of the people who died from malaria in the UK in 2019 had not taken the recommended prophylaxis.
Wow, that's huge. It really points to prevention failure, not necessarily treatment failure in so many tragic cases.
It really does. Globally, though, the notes do mention significant progress. Malaria deaths have fallen by 60% since the year 2000. That's a major public health success story.
But the burden is still heavily concentrated.
Oh, massively. Sub-Saharan Africa still accounts for something like 89% of cases and 91% of deaths worldwide.
Okay, let's talk about what it actually looks and feels like for the patient, the clinical presentation. What are the common symptoms listed?
It's the classic picture, really, that cyclic fever, chills, often quite violent, shaking chills, then profuse sweating as the fever breaks. Headache is very common, muscle aches or myalgia, and just feeling wiped out, fatigued.
Nausea, vomiting, maybe an enlarged spleen, too.
Yes, those are mentioned. And the notes get specific about the fever patterns, which can sometimes be a clue to the species, though maybe not always perfectly regular.
Right, the tertian and quartan thing?
Exactly. P. vivax and P. ovale typically cause fever spikes roughly every 48 hours. That's the tertian pattern. P. malaria causes fever spikes roughly every 72 hours, the quartan pattern.
And the notes also link P. malaria specifically with nephrotic syndrome, a kidney complication.
Yes, that's a specific association mentioned. And here again, that absolutely crucial point for two of these species. The notes reiterate the relapse risk for Ovale and Vivax.
Directly linking back to those dormant hypnozoites hiding out in the liver.
Precisely. If you diagnose Vivax or Ovale, you have to think about preventing relapse down the line.
What about timing? When do symptoms appear after infection?
It's variable, the notes say. Can be days, can be months after exposure. Falciparum tends to show up quicker, usually within weeks. Vivax and Ovale can take longer, sometimes months.
Which is another reason why that travel history is so vital, even if the trip was, quite a while ago.
Absolutely. And the notes highlight a challenge. The symptoms are pretty nonspecific. Fever, aches, feeling unwell could be loads of things. It's easily mistaken for other illnesses, especially in children, which can lead to dangerous delays in diagnosis.
So the absolute actionable key point from this section in the notes, always get a travel history. Ask specifically about malaria prevention, like prophylaxis use. And if you suspect malaria even slightly,
Test promptly, don't wait and see.
right. The notes list the common malaria symptoms, again, just for emphasis: recurring fever, chills, headache, myalgia, and GI upset.
And then they list signs of severe disease. But crucially, they immediately qualify this, stating these are usually associated with P. falciparum.
Okay, so what's on that severe list?
Impaired consciousness or confusion, shortness of breath, suggesting lung issues, any signs of bleeding problems, fits or seizures, signs of dehydration or hypovolemia.
Low blood sugar, hypoglycemia,
Yep.
kidney injury, pulmonary edema, or ARDS, acute respiratory distress syndrome.
Yes, all those. It's absolutely critical, as the notes stress, to remember these severe complications are overwhelmingly a feature of falciparum malaria.
They're rare in the other non-falciparum types like Vivax, Ovale, and malaria, although...
Although remember, P. Knowlesi is the exception in this non-falciparum group. It can cause severe disease too.
Got it. So how do we actually confirm the diagnosis investigations?
The notes are clear. Prompt and accurate diagnosis is essential. The gold standard, according to these notes, is blood smears.
That's looking under the microscope, right? Thick and thin films.
Exactly. Microscopic examination, usually with a gene sustain. This lets you see the parasites, identify the species potentially, and get an idea of the parasite load, the parasitemia.
But what if you don't have expert microscopy readily available?
Then the notes mention rapid diagnostic tests, or RDTs. These are like dipstick tests that detect parasite antigens in the blood. They're useful for quick results, especially if staff aren't trained in microscopy.
But they have limitations.
Yeah, they might not identify the specific species reliably or quantify the parasite load. Sometimes they can remain positive even after treatment. So microscopy is still preferred if possible.
And for definite species ID or for tracking purposes?
Nucleic acid tests, like PCR, are mentioned for that, more specialized.
Okay, procedurally, what are the key steps mentioned?
Two crucial things. First, you must notify the relevant public health authorities. Remember, it's a notifiable disease.
And second?
Send a blood sample to a specialist center like the Malaria Reference Laboratory here in the UK for confirmation and further analysis, like drug sensitivity testing maybe.
Right. What about other general lab findings the notes mention? FBC.
Yeah, full blood count. You'll often see thrombocytopenia, that's low platelets. Anemia is common too. Less often you might see a high white cell count, leukocytosis.
LFT.
Liver function tests are often abnormal, yeah. Might show raised bilirubin or liver enzymes.
UNEs.
Urea and electrolytes might show low sodium, hyponatremia, or increased creatinine, suggesting some kidney strain. Low blood glucose can also be present, though, again, much more common and severe in falciparum.
Okay, now here's arguably the single most critical lab test mentioned in these notes, specifically linked to treatment.
Ah, yes, evaluating G6PD activity. Glucose 6-phosphate dehydrogenase.
Absolutely essential, the notes stress, to check this before giving one particular drug.
Primacan, yes, this link is vital for patient safety. Primacan can cause severe hemolysis, a dangerous breakdown of red blood cells in people who are G6PD deficient. You must know the G6PD status first.
Got it. They also list other tests for very ill patients: blood gases, cultures, clotting, CXR, maybe even an LP.
Yeah, standard workup for a severely unwell patient, basically.
Okay, let's move on to management, specifically focusing on non-falciparum malaria, as per these notes.
Right, so treatment generally involves anti-malarial medications. The choice depends on the species, where the infection was likely acquired because of different resistance patterns globally and patient factors.
The notes mention chloroquine, primaquine, or maybe atovaquone malarone as possibilities.
Yes, and they also mention artemisinin-based combination therapy, ACT. The notes say it's recommended for areas sensitive to chloroquine.
That phrasing is slightly interesting, isn't it? Because ACTs are often talked about for resistant malaria, especially falciparum.
It is a slightly confusing phrase in the notes, I agree. Often ACTs are the primary treatment for falciparum, including chloroquine-resistant falciparum, but we'll stick strictly to what the notes say here. ACT is listed as a treatment option recommended for areas sensitive to chloroquine in this context.
Okay, now a key drug specifically for non-falciparum, primaquine.
Yes, absolutely key for P. vivax and P. ovale. The notes explain it's used after the initial treatment, which is often chloroquine, to deal with the liver stage.
Right, because that's the only way to get rid of those dormant hypnozoites.
Exactly. It's essential for eradicating the hypnozoites and preventing those relapses we talked about. Without primaquine for Vivax or Ovale, the patient is at very high risk of getting sick again later.
And the notes even say primaquine works better when taken with the chloroquine.
Concurrently, yes. That's what the notes suggest for effectiveness.
And we have to say it again because the notes stress it multiple times.
G6PD testing. Essential before you even think about prescribing primaquine. Cannot give it without knowing the patient's G6PD status.
Okay. Where is non-falciparum malaria typically managed? Inpatient, outpatient?
For uncomplicated non-falciparum malaria, the notes say management is typically outpatient, unless the patient has significant other health problems or comorbidities.
And that's a big contrast with falciparum malaria.
Huge contrast. The notes say falciparum requires inpatient admission, at least for the first 24 hours for monitoring. And severe falciparum cases need intensive care, often with IV artesunate or maybe IV quinine, much more serious up front.
The notes touch on drug resistance too. It's an ongoing issue.
A massive threat, yes. Monitoring resistance patterns is crucial. ACTs are currently the mainstay for resistant P. falciparum infections. The WHO is pushing hard to ban oral artemisinin in monotherapies, just taking artemisinin on its own to try and protect the effectiveness of the combination therapies.
And where is resistance currently the biggest problem?
Artemisinin resistance is mainly limited to Southeast Asia right now. But the notes highlight the huge risk if it spreads, particularly to Africa where the burden of malaria is highest. That would be catastrophic. So a really vital practical takeaway from the notes on management overall.
AL cases of malaria, regardless of species, should be discussed with infectious disease specialists or a local expert unit, and treatment should strictly follow current national guidelines like the UK HSA ones here. Don't freelance it.
Absolutely critical advice.
Okay, let's look towards the end game. Prognosis and complications. How do people generally do?
The notes state the prognosis for malaria is generally good if appropriate treatment is given promptly.
But the recurrence risk we keep mentioning for Vivax and Ovale due to those pesky hypnozoites.
Exactly. That's the caveat for those species. And the notes are very clear. Without treatment, malaria can be fatal, especially severe cases, which are mostly falciparum.
And let's circle back to that sobering UK statistic one last time.
87% of the 2019 UK deaths had not taken prophylaxis. It just hammers home the importance of prevention for ensuring a good prognosis. It often prevents the infection entirely.
The notes do mention the global success story again, that 60% reduction in mortality since 2000, showing that control and prevention efforts really do work on a large scale.
Yes. They also give a specific mortality figure for cerebral malaria, around 20%. But remember, cerebral malaria is almost exclusively a severe falciparum complication.
And prevention methods listed, we've touched on them.
Yeah, vaccines are starting to become available, which is exciting. Chemoprophylaxis, taking preventative medication. Insecticide-treated bed nets, ITNs, are hugely important. And behavioral changes, like using repellent and avoiding being outdoors dusk till dawn.
Right. Finally, complications. The notes start with a really important statement here.
Yes, a crucial qualifier. Complications are mainly associated with P. falciparum infection.
So the list that follows, we need to keep that firmly in mind. What's on the list?
Okay, remembering these are primarily falciparum related. Impaired consciousness or seizures, that's cerebral malaria. Kidney impairment or failure, metabolic acidosis, severe hypoglycemia.
Pulmonary edema, ARDS. Severe anemia, splenic rupture that's rare but dangerous. Coagulopathy or bleeding problems.
Shock, secondary bacterial infections or sepsis, multi-organ failure, something called blackwater fever, which is massive hemolysis causing dark urine, and ultimately death.
So understanding that distinction between non-falciparum, usually less severe, except Knowlesi, and falciparum, high risk of severe complications, is absolutely critical for managing patients and predicting outcomes.
Couldn't agree more. It dictates urgency, management, setting, everything.
Okay. We've really journeyed through these notes, haven't we? Covered the different species, the crucial life cycle details like hypnozoites, the key tests like G6PD.
And the different management approaches, especially for Vivax and Ovale, needing that extra step for relapse prevention.
We've seen the amazing progress globally, that 60% drop in deaths, but also these persistent challenges. the relapse issue, the looming threat of drug resistance, and maybe just the simple, tragic failure sometimes to use the effective prevention tools we already have, like prophylaxis.
Yeah, it's a mixed picture.
So, thinking about everything we've just unpacked from these notes, the biology, the drugs, the epidemiology, the prevention gaps, what single aspect, in your view, represents the most significant hurdle, the biggest challenge to actually achieving a malaria-free world someday? Is it finally cracking the hypnozoa problem? Is it stopping drug resistance in its tracks? Or is it something more fundamental, like just getting basic prevention prophylaxis bed nets effectively used by everyone who needs them?
That's the multi-billion-dollar question, isn't it? These notes certainly lay out all those different facets of the problem. Definitely something to mull over.
Indeed. Well, that pretty much wraps up our deep dive into these non-falciparum malaria revision notes. We really hope this conversation has helped to consolidate these important points and made them stick a bit better for your revision.
Yeah, these are definitely high-yield facts, pulled straight from the source material. Go back over them, maybe test yourself on the key differences in management steps.
And if you're looking for more resources to help you prepare, especially if you are studying for the MSRA, the notes themselves point you towards passthemsra.com.
That's right, and you can find free practice questions to test your knowledge over at freemsra.com.
Great stuff. Thanks very much for joining us for this deep dive.
Thank you.
We'll catch you next time.